and and a plug-in microphones and speakers, so
That
life
used
is
to be
good.
all it takes.
Yeah, I agree.
I just figured if worst case scenario, we do what we did last time where I was typing in. I'm like, this is not ideal. So I'm very
No.
happy.
No, I agree with you. I agree. Well, it's gonna be interesting now that the legislation's passed.
Yeah. A little bit of a different world now.
Yeah. I was at a legislative meeting yesterday and Senator Eckert said she was at a budget meeting and there's a $7 billion surplus right now,
Huh.
which I thought was interesting.
That's not a problem a lot of us have.
No, it's a little different than the old days. We were talking about deficits, so
A lot of opportunity there.
there is. Are you getting admitting popping up on your screen?
No.
Okay. I keep getting to admit people, so I'm admitting people.
You're the head of the whole shebang.
Boy, it's good to be, it's good to be there.
You're doing a fine job.
No, thank you. Let me know when you want to take over.
I had my minute in the sun. It was glorious and it was enough.
That's funny. I was telling people yesterday, I got my first deer of the season. Unfortunately, it was with my wife's car. About 6:30 in the morning coming back from BWI.
And you probably weren't in the frame of mind for that at the time.
Well, just driving along, the little Mini Cooper, driving along, and he jumps over the rail and hits the door and slides to the front.
Was the deer bigger than the car?
It was, but we're gonna get it fixed. Jeff, you're on mute.
Hi, Jeff.
Good afternoon, everybody.
Good to see you.
Good to see you guys too. So deer, I think I came in on the end of a deer.
I took my daughter-in-law to the airport at 3:30, and on the way back, 6:30, I was by 404, near the 404 light, and a buck jumped over the rail and into the side of my wife's Mini Cooper. And just talked to the insurance company today. They're gonna cut me a check and we're gonna fix it. I was able to drive it home, but it's a
Wow.
205 with 43,000 miles. I didn't want to lose that.
Worth much more than you'd get for it too.
Yeah, the guy said it was worth $6,900, so they're gonna pay out. And we're gonna use some used parts, so
Yeah.
life will be better. But
Yes.
Karen said that she wanted to be buried in that car, so we got to take care of it.
Not soon, though.
It's her baby.
No.
Getting a good crew today.
Yeah. Everybody's still signing on here.
Are we anticipating the usual folks?
I think
Yes.
so. There's Eric.
Hey, Eric.
Welcome. You're
Hey,
on mute.
folks.
There you go. Good to see you.
Hello. Good seeing y'all. Hey,
Mr.
guys.
Poole, how are you?
Good to see you.
Good to be seen. Did we know if Betty Buck is going to join us?
I think she was a yes.
Oh, okay, good. We'll wait. We got a minute or two anyway, so.
Just
Full
take a look.
group.
I feel like that's
Good.
correct.
Good afternoon, everyone. This is Jim Hawk. I'm home. I apologize for the Clint Eastwood voice, but I have my first cold since 2019, so I'm struggling with it.
As long as it doesn't come over the internet, I'm happy.
I understand that. I caught it from my wife, who caught it from my son, so it's been in the family.
All right. Well, I
Yep.
have 3 o'clock on the nose, so we're going to start the meeting with a roll call. So Chairman Silverstein, present. Vice Chair Barbara Wall,
Present.
Commissioner Eric Morset,
Present.
Commissioner Robert Poole,
Present.
and Commissioner Betty Buck. Are you with us yet? All right, so we have a quorum. I need a motion for approval of the October 20th, 2022 meeting minutes.
I'll motion to approve.
Okay,
I'll second it.
we have a second. All those in favor signify by saying aye. Aye. Opposed, same sign. All right, Mr. Kelly.
Thank you, Mr. Chair. Good afternoon, everybody. And just for the record, I did have verification that Betty would be attending today, so I would expect she may be on briefly.
Excellent.
Okay, just to give you a quick rundown of what's happened since we last met. We had 9 different incidents over the period of the month. When I say incidents, that's generally, we do a lot more than 9 things. I should explain that. We do a lot more than 9 things, but something that rises to the point of actually getting a case number are significantly fewer. So we do a lot of things that end up being maybe a training moment, an educational moment, maybe just, maybe sometimes don't even turn out to be anything. When they rise to the level of getting a case number, then I would call them an incident. So we had 9 incidents last month, and actually one right before airtime as well up in Cecil County on I-95. That's not going to be counted in that group. We'll talk about that next month. In those instances, they were all tobacco related. We had no alcohol violations this month. Of the tobacco, the other tobacco products, we seized over 28,000 sticks of other tobacco products and 180 packs of unstamped cigarettes. Talk about reports just for a moment. We have a couple that are in the middle of being completed. Actually, we're very far along. One of them is our annual alcohol and tobacco tax report. And what's significant about that? First of all, it is the repository of almost all significant data. I use it throughout the year, and especially when the General Assembly is in session. It just has a lot of different information in it. Stats, facts, and figures, just a lot of that kind of thing. Included in that also is a separate report from each of the breweries that we're required to get, which really outlines their production. You know, there's 100 of them, and we get all of their production levels for the year and amounts that they sell to wholesalers, amounts that they sell out of their tap rooms to visitors, and maybe even to people who are consuming on premise. So that report is all part of this pretty large annual tobacco tax report. We're well along the way of getting that done. December 1st is our due date for that. Another report that we're working on, and this is one we're doing in conjunction with the Department of Health, is really to see what the impact and effects of the governor's executive orders in expanding many of the privileges for the alcohol industry, and particularly retailers. What impacts happened? What happened economically? Was it something that was beneficial? Did it work? Did it really not work? Do people want to see it continue? And what happened health related wise as well? So obviously, the ATC is doing the portion of it that talks about the economic impact and the trade practice issues that may have come up from our portion. Then we did our portion. We passed it over to the Department of Health, who has done their portion, which are the different various health consequences. We've both submitted our edits on each other's parts, so it's really through the final phases of being completed. That's also due in December. I think that's actually due by the end of the year, but it's very close now. We're just finishing up some of the final edits on that. And lastly, we had a very small role in a, generally it's a study and then a report on minority participation in the alcohol industry at the various different tiers and levels. And we had a very small role. It's the Governor's Office of Small Minority and Women Business Affairs that's responsible for this report. And in talking with them, all they really wanted from us was good list of contacts of people that they could talk to in the industry to find out representation in various levels. We've already provided all of that to them, as well as contacted each of the various industry levels to let them know what to expect and to maybe start preparing. So when they get those calls, the information's ready and available. So, Mr. Chair, that would be the extent of my report for this month.
Okay. New business.
Yeah, yes. I will just continue on. So you probably don't know, but I have to pay attention to politics. I'm sure many of you do not at all. We had an election last week, and a whole variety of things is going to happen. Obviously, we're getting a new governor, and I expect at some point that We'll be contacted by a transition team member and I guess talk about the future of the ATC, what it's going to look like, who will be involved. I think you guys get to be involved regardless, and we'll see what happens with anybody else. But also of great significance was the referendum that was created by House Bill 1 last year, which simply said, would you support the legalization, adult use of cannabis for people over the age of 21? And by something like 65%, the citizens of Maryland passed that referendum. And now that requires the General Assembly to go to work, to come up with policy and laws and rules about how to implement this. But one of the things that was really significant in House Bill 837, which was a bill that started to address some policy issues, in one of the special sections at the end, we call it uncodified language. And I don't mean to talk down to you, but just to explain it, there's language which is very clearly law, and it references sections of law and articles of law, and it resides in law. So you look in a law book and you'll see it. Then there's always the sections toward the end. I call them the special sections, but they're uncodified language, meaning simply they're not law, but they carry the weight of law. And at least they carry the weight of law until something else happens to change that. And in one of those sections, the General Assembly said very clearly that if House Bill 1 passes referendum, which it did, that it is the intent of the General Assembly that the Maryland Medical Cannabis Commission, which is the LaPrade Commission, would fall within the office of the Executive Director of the Alcohol and Tobacco Commission. Now, it doesn't say that it happens today or January. It just says that it will. They still need to take some action on that, but they've certainly expressed what their intent is, that we become the successor agency of the Cannabis Commission. And if I could, Mr. Chair, I'd like to introduce Mr. Will Tilburg, who I know you've met. Will is the Executive Director of the Maryland Medical Cannabis Commission. And I've asked Will and the chairman, actually proud of me, if we could maybe get this primer on what it is they do. And Will's graciously agreed to come. And Will and I've known each other for a long, long time. And I think some of you have met him before virtually as well. He's been involved in public health, in tobacco enforcement related issues and guidances for years. We've known each other for a long time. And then he moved into this role several years ago and has been at the helm of it. So again, Mr. Chair, if I may, I'd like to defer to Will and ask him to give us all a little bit of a primer on what it is the Maryland Medical Cannabis Commission does.
We appreciate him joining us. Thank you.
Sure. Will?
Hey, Jeff, I'm here. Good afternoon, everybody. I don't seem to have the option for video. Oh,
You were on earlier, Will.
I was, and I'm back.
There you go.
Okay, and so I do have, if I can not bore you too much, I have some slides as well, some visual aids to assist. I don't know if I have the ability to share my screen. If not, I can.
I think you should, Will. In the upper right-hand corner next to the leave button, there's a share. Should be a share button.
It says for me, only meeting organizers and presenters can share. So if not, I'm happy to just go with it.
Give me a second and I'll see if I can't get that squared up for you. And Betty's coming on board now.
Yeah, I see Betty Buck is joining us. Welcome.
And while we're working on that, I'll just introduce myself again. Will Tilburg, Executive Director for the Maryland Medical Cannabis Commission. Pleased to be with you here today and discuss the medical cannabis program in the state, and then also the makeup of our commission and sort of how it functions and what it is that we do. And I can do that orally, or if we have a chance, I can supplement with slides. And I've been through in my time a few presentations by Tom Akris in your all's shop, and he goes back to the Volstead Act and the 18th Amendment and the 21st Amendment. And so cannabis does not go that far back. Although for those conspiracy theorists among us, the same individual that was in charge of the U.S. Department of Treasury enforcing prohibition then argued to Congress to criminalize cannabis shortly after prohibition ended. And so some have said that it was that office looking for continued justification to exist. So cannabis was, after alcohol was made legal again in 1933, cannabis was made illegal for the first time in 1937. I think I have the ability to share now. I have tap danced my way through that. beginning.
We see your screen.
Fantastic. Okay. So I gave the background. So today we're going to talk about some of the history of evolution of cannabis in the state, the current program and the structure of our commission, and what it is exactly that they do along with staff support. So as I was mentioning, we don't have the 80-year history. Really, the change from complete criminalization in the state of cannabis started to change in 2011 when we see the General Assembly adopting affirmative defense for individuals who can demonstrate that they're using cannabis for medical purposes. That's followed up 2 years later by the first attempt to establish a medical cannabis program. In this model, it was academic medical centers. So it said, University of Maryland, you can grow cannabis and dispense it to patients. And they quickly said, no, federal law does not allow that. We're not going to do that. So the General Assembly came back the next year and created what was initially the Medical Marijuana Commission, later named the Medical Cannabis Commission, to license and regulate private entities to grow, process, and dispense cannabis within the state. So following the creation of that commission, we developed regulations and it had an initial licensing round for, again, growers, processors, dispensaries. So that is the entities that cultivate cannabis, those that take the cultivated cannabis and manufacture it into tinctures and salves and vape cartridges and any other product that's permitted within the state. And then the dispensaries, the retail arms that actually distribute the products to qualifying patients. So that round happened in 2015. Initial licenses were awarded in 2016. And then December 1st of 2017, we see the first medical cannabis dispensaries open in the state. And within a few months there of 2017, there was significant concern about the ownership makeup of the medical cannabis businesses and not properly representing the diversity from a race, gender, ethnicity perspective of Maryland. So the General Assembly came back in 2018 and passed what is known as the Medical Cannabis Commission Reform Act that reconstituted the commission itself and allowed for the award of additional licenses and put in place certain diversity requirements for the award of those licenses. That process then for those second round of licenses took place in 2019 and 2020. And so we have now 22 growers in the state, 28 processors, and around 100 dispensaries. And as soon as the second round of licenses were awarded, the state quickly sort of turned its focus to, well, what's next? And what next has been this path towards legalization of adult use, and that is any individual 21 years or older. And so what we saw during the 22 session was the passage of HB1 and its complement HB 837 that Jeff was referencing that led us to the election last week and the passage of question 4. So that is a very quick timeline of the last 10 years or so and how we got to where we are with MMCC staff preparing to transition to ATC at some unknown later date. Switching gears, I just want to provide a little of the background on what actually the medical cannabis program is in the state, and then talk about the functioning of the commission, what it is that the commission's role is, and what the commissioner's role is within the program. So as background, we are, like ATC, an independent commission. Unlike ATC, we are nested within the Department of Health. So while the commission members are separately appointed by the governor, and we operate independent of the department, we do receive certain support services like human resources, procurement, information technology from MDH that supplements our own staff here. Within statute, our mission is to provide a safe, effective, and consumer-friendly medical cannabis program for qualifying patients. The decision makers within our program are the 13 volunteer commission members who serve 4-year terms. 9 of these folks are appointed directly by the governor with advice and consent of the Senate. 3 additional members are selected by the governor from a list of individuals provided by the Senate President and the Speaker of the House. And there's 1 member who is a Secretary of Health or a designee. Currently, we have 12 members with 1 vacancy being the Speaker of the House's representative. The commission members themselves are supported by 77 full-time employees. And unlike ATC, we are specially funded. 100% specially funded. So that means that the fees that are assessed to the businesses, the annual grower, processor, dispensary fees are what fund our staff, pay for our lease, cover our budget. And in FY21, that budget was about $9 million. That's the makeup. What exactly is the role of the commission? We are regulating medical cannabis. What does that mean specifically? So first, as I was discussing through the evolution, licensing these businesses. So licensing growers, processors, dispensaries, and then separately registering the support businesses, the delivery services, secure transport, security agencies that support the growers, processors, dispensaries, as well as registering and overseeing the patients, caregivers, and certifying providers that operate within the program. Once licensed, we inspect businesses and the labs that we oversee for compliance with regulatory with the regulatory requirements. The body holds administrative hearings and levies penalties against violators and assists patients and providers with troubleshooting any access they have with registering or obtaining medical cannabis. And then lastly, we promulgate and implement all regulations and conduct education throughout the state. And this is one of the true core components of our role. Cannabis is new. Cannabis has a stigma, continued stigma in the state and across the country, and there's not a lot that's known about the program. So a significant amount of our work is educating our state colleagues, local governments, general public, legislators, others on what the program is, what the laws are surrounding cannabis, and the like. Unlike ATC with the licensing of alcohol and tobacco, there are strict statutory requirements, limits, I should say, on the number of businesses that are allowed to operate in the state. I referenced this earlier. Within statute, there are only 22 growers that are permitted, 28 processors, and dispensaries, 101. The ancillary businesses, those businesses that provide support services, are not limited in statute. And we've presently registered more than 50 of them. And one of the key members of the ancillary business group is laboratories. So their independent testing is required for all products to be sold in the state. We register those businesses. We conduct inspections to make sure that they are testing products appropriately and enforce regulations against the labs as we do with other businesses. It's important to also note what we don't do presently, and this is in contrast to ATC and to the Field Enforcement Division. The use, possession, and distribution of illicit cannabis is under the power of state and local law enforcement. So if there is an unlicensed dispensary in Baltimore City, MMC, while we have an enforcement staff, they are only authorized to issue civil penalties and fines to our licensees. So an unlicensed entity in Baltimore or anywhere else in the state falls outside of our scope. That is distinct from the Field Enforcement Division at ATC. And then second, we rely on, so patients receive written certifications, a rough equivalent of a prescription to obtain medical cannabis from certain providers in the state. And the state licensing boards retain primary authority over the physicians, nurse practitioners, et cetera, that issue these written certifications. So we typically work in concert if a certifying provider may be issuing written certifications to individuals who they should not be. MMCC can't really go after them. We can work in investigations with the boards to go after any bad actors. Switching to the commission's governing structure, the full commission body is required to meet in statute 4 times a year. I think you all have every month, but typically we do meet each month, sometimes off for one of the holiday months. And below the full commission, which again is 13 members at its full capacity, there are several standing committees and then subcommittees that meet as needed, typically in the week or two before a scheduled full commission meeting. We have a chair, vice chair, and then committee and subcommittee chairs as well. The 5 standing committees are compliance, executive, finance and budget, policy, research and education. I'll just tick off quickly what they do. Compliance is as what it sounds. They oversee administrative hearings. They oversee case resolution conferences. So that's bringing in violators to reach a consensus decision in agreement, a joint resolution. And then they also, in the compliance committee, can bring charges against violators, and they make recommendations on sanctions to the full body. The executive committee approves all legislative matters. So during legislative session, that's the group the staff work with most closely, providing our positions on certain bills. They approve all mandatory legislative reports, and they're authorized between meetings to make decisions on any matters that may come up in an urgent fashion. The Finance and Budget Committee, as it sounds, reviews and approves the annual budget. Policy is one of the more active committees that we have because of the nascency of the program. We're constantly doing a lot of rulemaking and revising, and so they oversee the public meetings where amendments to our rules are considered, and they make proposals to recommendations to the full body to change regulations. And lastly is the Research and Education Committee. They oversee any research activities, and they also develop educational materials on medical cannabis, on the benefits, also the health risks, and they consider petitions to add new conditions to the list of qualifying conditions that are authorized under law to become a patient. We also have two subcommittees. One considers submissions for edible cannabis products. We do allow edible cannabis products within the state, but they have pre-market approval is required. So any products come through and that committee reviews them. And then final review subcommittee deals with licensing of businesses and transfers of ownership and issues like that. This is just a brief slide showing the structure. The commissioners are the decision makers in statute. So they are the ones, not staff, that can license, that can adopt regulations, levy penalties, these types of things. And you see underneath the staff, the various departments that we currently have, medical cannabis registration program, enforcement, policy, communications, IT, research and education, and budget and finance. Again, that's about 77 FTEs presently. Quickly, how you become a patient within the state, since this is not your typical subject matter to date, it is a two-step process. And the first one, you come to our website, and that takes you to the Maryland One Stop portal, the state's centralized license and registration application portal. And a patient completes a registration, and it then is reviewed by our staff to confirm that the individual lives in Maryland or is receiving inpatient care in Maryland, and that they are over the age of 18. Those are the requirements for registration. That does not authorize you to obtain medical cannabis. Once you get that registration, you have to separately see a certifying provider, a medical provider in the state, who issues you a written certification, which is the equivalent of a prescription in this case. There are also caregivers, who are individuals that patients can designate as the person to go into the dispensary on their behalf to obtain the cannabis and also help administer the cannabis. Any patient may have a caregiver. If you are a minor, you have to have a caregiver, and that caregiver has to be a parent or guardian that oversees the administration. Qualifying conditions, glaucoma, PTSD, and the rest are symptomatic, related to what you would see with chronic disease and medical issues, things like cachexia, anorexia, wasting syndrome, and chronic and severe pain. Number 3 there on the list is what separates Maryland from a lot of states, and presently there are 37 states in the country that have authorized medical use of cannabis. Is that it's in the determination of the certifying physician or other provider that if medical cannabis would benefit you as a patient and those benefits outweigh the potential risks, then it can be authorized. And so that's sort of a catch-all that Maryland has used that not a lot of other states have to date. Providers, like the patients, need to register with us. In order to do that, they have to fill out an application, which is basically that they are licensed and active in the state, and they have a controlled dangerous substances registration. We have APIs set up with the different boards. So if they are active, if they are licensed, if they do have a CDS registration, it's a pretty automated process to issue the certifications. Written certification, again, is the equivalent of the prescription. Because cannabis is a Schedule I substance under federal law, providers cannot issue prescriptions for it, and so the written certification is a state equivalent to that. In order for the commission to determine who should have access to medical cannabis within the state. Last piece before switching to just quick touching on the size of the program right now. Limits on medical cannabis. A patient is not authorized to just have any amount. There are limits within law. It is what would be a standard 30-day amount. That's 120 grams of flower. It's approximately 4 ounces, or 36 grams of THC. So when an individual goes into a dispensary to purchase whatever product they buy, the allotment is reduced based on how much THC and the size of that product. If a certification from a provider is not used within 120 days, it's no longer valid. A patient may only have one provider and one written certification at a time, and they have to renew that certification, including a visit to a provider, at least once every 365 days, so once per year. One of the frequent questions that I receive is what separates the product in medical cannabis dispensaries from those that are, from the illicit market or the gray market, and why should the state legalize? And there's a whole host of reasons that states legalize adult use cannabis. A lot of it's tied to undoing the criminalization of the drug, and so expungement and the like, but also bringing products into a regulated market means that you can test them for things like heavy metals, residual solvents to ensure a safe product, and you can also track it to ensure that there's not diversion to those that shouldn't be accessing it. So those are two critical pieces, testing and tracking, and I'll just touch on them briefly how they work here in the state of Maryland. So as I mentioned earlier, every single product that is sold at a dispensary is part of a batch that has to have passed laboratory testing prior to sale to a qualifying patient. So the lab tests themselves are testing for safety and then also potency. So it's making sure certain things are not within products like heavy metals, like residual solvents, like impurities like salmonella or E. coli, but then also helping the patients understand what is in the product in terms of cannabinoids. So the common ones that most folks are familiar with are THC and CBD. There are more than 100 cannabinoids. And so within the packaging, the labeling of the product, it has to list each cannabinoid that's within the product and the amount that's within the product. You're going to see that on the package itself and through what's called a certificate of analysis that any patient can request, that is to see the exact lab test for a certain product. So again, every product has to be tested, and this is important because when you buy prescription drugs, dietary supplements, food products, etc., there are federal standards for testing, for manufacturing and for testing. And because cannabis, it remains federally illegal, there are no federal standards here. So MMCC, the state of Maryland, had to create its own standards in terms of what can be in a product and what cannot be. And absent federal oversight, we've worked closely with states around the country to sort of standardize acceptable levels of heavy metals and things within products, and that remains a work in progress. So testing is an important piece that differentiates the illicit market from the legal market, but it's also an area where we're continuing to improve as we learn more about the plant and the products related to cannabis. And then seed to sale is, as the name suggests, all products in Maryland are tracked from as soon as a plant is immature and 4 inches high, it is tagged with an RFID tag, and that product then is tracked throughout its life cycle as a plant, and then to whatever product package it ends up in, it has that same RFID tag. So it can be tied to the exact lab test, the exact batch that it came from. And this is really critical from a diversion standpoint to know where product is ending up, but then also from a health and safety standpoint. When we have had, say, it turns out that a product had pesticides, unlawfully put on a product, we're able to go into Metrc, immediately put an administrative hold on every product that came from that batch that had that issue, and immediately put it on hold and then have a recall. And so it's a really great public health and safety mechanism to prevent outbreaks or to address outbreaks as soon as they happen that a lot of other industries don't have at present. mostly covered this slide. So in the interest of time, I'll just switch to the program data. Talked a little bit about the length of the program. Law started changing in Maryland about 10 years ago. The commercial market has existed for the medical program for the last 5 years. Talked about the setup of the commission. What exactly is then the size and scope of the program? We tend to look at two different metrics. One is patient numbers, and the other is retail sales to track this. And so what the patient registry first opened in 2017. You can see in that year we had about 11,500 patients. At present here in April, or as of that should say October. So as of October 22, we have 162,000 registered and certified patients. So there are 162,000 Marylanders who are able to presently go into a dispensary and purchase cannabis from them. The effect of the referendum is as soon as there is an adult use market, this number will go from 162,000 to more than 4 million Maryland adults that would be able to access lawful cannabis from dispensaries. But you can see here the growth and trajectory of the program over the last 5 years. Lastly, economic metrics, retail sales. 2017, not a very robust year. We only had 1 month of sales at the beginning. There's only 5 dispensaries, but you can see continued growth throughout the years. 2022 is going to end up with less total retail sales than 21, but there's actually going to be more pounds of product sold and more overall transactions. The drop in total sales is actually related to the drop in wholesale prices. So as growers have gotten better at what they do, the cost of doing business has gone down. And so what we saw at the outset of the program was about $6,000 at wholesale for a pound of cannabis, and it's now hovering around $1,000. So the price to cultivate, to process, to sell has dramatically reduced, and so we are seeing probably a slight reduction in total sales for the year, even though the number of transactions and number of patients has continued to increase. That's my spiel. It's a pleasure to meet all of you here today, or see some of you again, introduce you to the world of medical cannabis. We're excited to work with ATC in the months ahead as the General Assembly figures out what comes next. And we're very much looking forward to the partnership with ATC. As Jeff said, he and I have worked together for a long time. We, for the mandated report that the two commissions had, I got to know, a lot of the rest of the senior team at ATC. I think that we've gotten along really well, and there's been a great synergy, and we're very much looking forward to being a part of the Alcohol and Tobacco Commission in whatever date in the future the General Assembly decides. I'm happy to answer any questions. I know I went through things quick. I have a tendency to talk fast, and I will give you back your screen if I can figure that out. Did I get it?
Good job.
All
Thank you very much, Will.
All right, thank you.
Well, I just want to say I had an opportunity to sit in on one of the sessions where your commission, the Alcohol Tobacco Commission, met to talk about how different personnel would be reallocated. And I was very, very impressed with the professionalism on both sides and the quality of the report that came out of those meetings. So thank you very much. And Jeff, thank you for everything that Tom did working on our behalf. Anybody have any comments, questions?
I do. I tried to be a good girl and put my hand up. First of all, I'm sorry I was late. I struggled getting on the Teams thing. No matter what I hit, it kept saying sign in, sign in. So I apologize for being late. And I have to tell you, after raising 4 children, I am still extremely naive when it comes to this whole thing. After being in the beer business my whole life, Jeff, you all taught me quite a bit about tobacco. I was never a smoker, and now I need to learn. So you said that your job was education. Anything you can send my way as far as education about cannabis, I would truly appreciate, because I'm starting from square one. I know absolutely nothing.
Yeah, absolutely. I mean, happy to. And it sounds like Commissioner Poole, you were in agreement.
I am, and so one of the question is there discussion about limiting the quantity of THC in the product that's available to the public?
There is. So separate and apart from the report that our commissions jointly were responsible for, MMCC was asked to put together a report that covered a lot of different issues related to adult use. So home cultivation, on-site consumption establishments, and also certain aspects of regulation to reduce use by minors. And caps are one thing that come up frequently in that discussion. Right now, our medical program for edible products does have limits on the amount of THC that can be in a product per serving, as well as per package. And so for per serving, it's 10 milligrams of THC, per package 100. That's pretty standard across the US in terms of adult use programs. We would anticipate that a similar cap would be placed on an adult use market, though that's up to the General Assembly. When you go to other products, things like flower itself or vape cartridges, other concentrated products, there is ongoing debate in public health circles about whether that's a good thing. Because the question is, if you're saying you're not going to have 100% pure product, what other stuff are they putting in it? And so something that we experienced, and I think that you all had it, Avali a few years ago, the vaping lung injury was tied to a lot of illicit THC vape products that had vitamin E acetate and other additives in it that were causing these health issues. And so the concern is, if you're just going to say, well, you can only have X amount of THC, is what else are you putting in the product? So in that report that I referenced, we made the recommendation to continue the edible restrictions, and separately from the regulatory body, there is in the legislation created a Cannabis Public Health Advisory Council. And we recommended that body, which is going to be made up of elected officials, public health officials, Secretary of Health, other members, that they look at this issue more in depth as part of their recommendations, because it's something that as cannabis regulators we're sort of wrestling with now about how best to deal with. One of the potential solutions is tying taxation to THC level, so that you're not saying what needs to be in the product, but you're sort of making it potentially prohibitively expensive to have super high THC products.
And based on your knowledge and experience, so if you look at the glide path of this product as it's evolved in the state of Maryland, have there been studies completed on the efficacy of the claims made by the manufacturers? Are there studies that are available, and are there also, obversely, indications that there have been significant problems, and are those studies available?
Within our program in Maryland, the statute is clear that medical claims, therapeutic claims, cannot be made absent the same level of data that FDA requires. So in effect, what that means is our products are not accompanied by medical claims, because of the Schedule I status of the drug, the types of clinical trials you need to do largely can't be performed. So these products are being, written certifications are being issued by providers, but it's not based on clinical trials of certain efficacy, effectiveness of the product. With that said, there is a growing body of evidence that cannabis, not a particular strain or product, but itself, the cannabinoids, THC, CBD, others, are very effective in treating chronic pain and other things like PTSD. So there is a growing body that the plant itself, the drug itself, is effective at these things. That's not necessarily the individual products that are sold, because those have not gone through the clinical trial level review that you would see with prescription drugs.
Got it. Thank you.
Sure. And going back to the initial question, I am happy to share a lot of information. I mean, this is going to be an ongoing conversation in the months ahead, and happy to share sort of our medical cannabis 101 starter kit that we have. Absolutely.
Hi, my name is Vanessa Michelle Deeks, and I'm with the University of Maryland School of Pharmacy. And you mentioned something about the Research and Education Committee, and I want to know more information about that, like how to be involved in the committee.
So the committee is part of our commission, so it's made up of our commission members, and their focus now is largely on educational materials. I think a potential better avenue is that Public Health Advisory Council that I referenced. And before I get into that, very happy to connect you with staff that work with the Research and Education Committee. They've been doing a lot of cool work, and so we can take care of that. But in terms of a public engagement, when we look to the future of medical use of cannabis and the expansion to adult use of cannabis, this Cannabis Public Health Advisory Council that is created effective January 1st, now that the referendum is passed, is going to be a public body that's meeting and soliciting public comment, feedback on a wide range of public health and research issues. And so that's going to be a great avenue. So if you can email me, and it's William, I had it on the slide, william.tilburg@maryland.gov. I can connect you with our staff that work on these issues. And I also suggest you follow the Public Health Advisory Council.
Thank you.
Other questions from the individuals on the call?
I actually have one, Will. Just curious, you mentioned the monthly limitation in dosage, and that when they make a purchase, it's subtracted from that limitation. How is that tracked? Is it through that metric software, or how do you track the personal purchases of each of the patients?
Yes, so it is through both so Metric does it, as well as I was mentioning Maryland One Stop, where patients, providers, others register. That also has an ongoing public facing portal where patient Will Tilburg can log into his account and see what his allotment is remaining for the month. So the formula of weight to THC is complicated. I'm an attorney. They've shown it to me 1,000 times. I don't understand it, but patients can log in and see that. And so it's in One Stop for patients to view. The dispensaries can see it there. They can also see it through Metric on the back end. So that is tracked in real time. Maryland, that's one of the things that sets Maryland apart. A lot of times states have limits, but it's a batch overnight, and issues were presented where patients could go to a bunch of dispensaries in a day and exceed their allotment. And so Maryland, when creating the program, set up this real-time requirement, which is actually pretty onerous at the outset, but it's a benefit to patients so that they can see in real time what their allotment is.
So is that done, is that populated by like a POS at the dispensary? Or is it something that perhaps a dispensary staff has to enter as soon as the purchase is made? Most
typically, a dispensary has a third-party POS system that connects with Metric. So they're required to sort of enter it through Metric, but oftentimes they have a more user-friendly third-party POS system that does that automatically. So they're ringing up the sale, and it automatically connects to the state system to reduce the allotment.
Thank you.
Mr. Kelly, anything else?
No, Mr. Chair, that's it for us today.
Okay. Will, thank you very much for joining us. I think we're going to need a lot more information as we go forward. I've read a couple of articles. I see that legislative committees are already meeting and discussing this issue, and we'll be getting more information down the line. I need a motion to adjourn.
So moved.
All right. Commissioner Buck, second.
I second it.
Commissioner Poole, all those in favor signify by saying aye. Aye.
Aye.
All right,
Well,
we
thank
are
you.
adjourned. Thank you.
Well,
Thank
thank you very
you.
much.
Have a great Thanksgiving.
See you guys.
Thank you.
Great Thanksgiving, everyone.